Hello, 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 ladies and gentlemen. Hello. Today we are talking about lower airway disorders. We've already gone through upper airway disorders and how to maintain that airway. So now what we are talking about is respiration. So when we're talking about upper airway, that was all about ventilation, getting air into the body. This is now about respiration. The air has no problem getting into the body, and now does the body know what to do with it and how to utilize it? And also, we are going to talk about infectious uh, lower respiratory diseases, flu, pneumonia, TB. And that is the reason why there are so many slides in this presentation, because I have melded both topics. So, the class outcomes for lower airway disorders is to apply the pathophysiology of the lower respiratory tract to clients presenting with lower respiratory disorders and chronic airway disease and/or disorders. We will identify the importance of performing a complete health history and assessment, determine possible complications associated with lower airway disorders or chronic airway disorders. We will identify the clinical manifestations of lower respiratory infections. We will develop nursing interventions for clients with lower respiratory disorders, develop nursing interventions for clients with exacerbations of chronic respiratory diseases or disorders, and develop a teaching plan for clients with chronic respiratory disorders, because we are nurses after all. So, all lower airway disorders negatively will impact oxygenation, ventilation, the gas exchange, and then tissue perfusion. Some lower airway disorders can be chronic and progressive, such as asthma and chronic obstructive pulmonary disease, otherwise known as COPD. They will require meticulous management and lifestyle adjustments to achieve maximum wellness. And all patients with lower airway disorders will require thoughtful nursing care, support, and education to best manage their disease. So, we are going to talk about asthma. Asthma is a reactive airway disease, much like an allergic disorder, but it is classified as a reactive airway disease. So, it is a chronic condition, and it is similar to an allergic disorder in the fact that there is a trigger. So, asthma is more common in women than in men. Our risk of death will increase with age, and risk factors will include family history, a history of eczema or a skin disease, and the presence of allergies such as rhinitis. So, the pathophysiology of asthma is that it is a chronic lung disease that is characterized by intermittent, reversible airway obstruction resulting from inflammation of the lungs' airways and a tightening of the muscles that will surround those airways. The condition will affect the bronchial airways, not the alveoli. So there is nothing wrong with the gas exchange. Again, it is getting air down to where it needs to be. So there was airway obstruction and bronchial hyperresponsiveness. Bronchospasm or constriction of the small airways and underlying inflammation is easily triggered by exposure to an irritant or a risk factor. So again, there is that trigger. So, ladies and gentlemen, listen up, and then listen up for the first time. Risk factors will include cigarette smoke, mold, pollen, dust, animal dander, air pollutants, occupational irritants, viral infections, nasal polyps, allergic rhinitis, food and drug allergies, and emotional stress. So, pretty much anything, right? Exposure to irritants will trigger an inflammatory response. So, as a part of the immune activation, IgE antibodies will bind to receptors on mast cells, causing degranulation, and the release of inflammatory mediators such as histamine and then leukotrienes. So vasodilation will occur and increase capillary permeability. Airways will become edematous. Basophils and neutrophils will increase, which will stimulate the production of the mucus. And then thick, tenacious mucus will cause a thickening of the airways and bronchial hyperresponsiveness. Ladies and gentlemen, please take note. Release of histamine will also cause a constriction and spasm of the smooth muscles that will surround the bronchial tubes. So, bronchospasm of the bronchial tubes will occur. Bronchospasms will cause further narrowing of the airways, and bronchospasms, mucus production, and edema will result in obstruction to the flow of air into and out of the lungs. Clinical manifestations of asthma. So after exposure to the trigger, the client will exhibit clinical manifestations such as wheezing, dyspnea, coughing, increased sputum, and then an increased respiratory rate. Clients may also experience chest tightness and tachycardia, which may be secondary to decreased oxygenation, anxiety, or a side effect of treatment with a bronchodilator. Classic sign is the inability to speak in full sentences. So, diagnosis of asthma will also include the frequency of symptoms, triggers of specific activity, or the time, meaning the time of day, evening, spring, or fall. Is this happening routinely? Does it happen occasionally? How long the symptoms last? And mechanisms the client uses to relieve the symptoms. What do they do on their own to help themselves? Chest x-ray is done to rule out any other respiratory conditions and to monitor progressive changes in the chest. Pulmonary function tests are a predominant feature in evaluating asthma, and they are a group of tests to evaluate the functioning of the respiratory system. Spirometry is a test that will measure airflow and lung volume. One of the major tests of pulmonary function is the FEV1, forced expiratory volume in 1 second. FEV1 will measure the amount of air that can be forced out of the lungs after a full inspiration. The volume is going to be measured at 1 second. Measurement is compared to a normal person's predicted volume based on age and gender. A decreased result in this test of 15 to 20% below the predicted value for age and gender is a diagnosis for asthma. An increase of 12% after administration of a bronchodilator is also diagnostic of asthma. Peak expiratory flow readings will measure the maximum airflow expired during a forced expiration. The client's peak flow readings are compared to the personal best reading with a reading obtained during an exacerbation or what we call an asthma attack. So clients are encouraged to monitor their peak flow values. The reading done during an exacerbation as compared to a personal best will allow the patient to recognize the severity of their own respiratory distress. The client's asthma action plan is based upon the peak flow readings. Pulse oximetry is a non-invasive method for measuring oxygen saturation. Another term would be SpO2. It can be used to help determine the severity of respiratory distress. Normal pulse oximetry value is 95 to 100%. We know this. Pulse oximetry monitoring will detect desaturation of hemoglobin before the client will exhibit any symptoms. Arterial blood gas monitoring is an invasive sampling of arterial blood to measure oxygenation of the blood, acid-base balance, and the partial pressure of carbon dioxide, what we call PaCO2, Arterial blood gases will identify the client's response to oxygen, ventilation, and medication. Once asthma has been diagnosed, the disease, is classified based on the frequency and severity of the symptoms. It can be classified as controlled, partially controlled, uncontrolled, or an exacerbation. And these guidelines are set by the Global Asthma Initiative. The client is given an asthma action plan, which will assist with decision making. The plan will identify the severity of symptoms based on the peak flow readings, prescribed medications, and then their symptoms. So, treatment of asthma will include assessment, monitoring, control of environmental factors, pharmacological treatment, and then education. Assessment is similar to the process for diagnosis. Frequency of symptoms and triggers should be monitored. Pulmonary function tests should be conducted on a regular basis to track response to therapy. Peak flow readings, pulse oximetry, and ABGs are utilized during an acute exacerbation to determine the severity of the attack. Control of environmental factors is a necessary part of the education program. Irritant exposure should be reduced once the irritant has been identified. Environmental smoke is associated with increased symptoms and decreased lung function. Clients should be advised not to smoke or to be exposed to what we call secondhand smoke, another family member, a visitor, a guest, anybody else in the home that is smoking in the home. So, ladies and gentlemen, listen up, and listen up now. Clients should be advised to be aware of the levels of air pollution and avoid outside activities if the level is high. Clients should avoid fumes from wood-burning stoves, fireplaces, using aerosol sprays, and strong perfumes. Animals and or birds should be removed from the home if they are sensitive to the dander. Stress and depression may also be a factor that can precipitate an asthma attack. Ladies and gentlemen, please take note. So, medications for asthma. Pharmacological treatment is based on the client's classification and level of control. The classification of severity will determine the type of medications that are needed to best control the symptoms. Classifications of medications will include anti-inflammatories, bronchodilators, and anticholinergics. Anti-inflammatories, typically inhaled corticosteroids, will reduce mucus production and swelling, making airways less sensitive and less likely to react to triggers and then cause the symptom. So, ladies and gentlemen, listen up, and listen up right now. Bronchodilators, such as beta-2 adrenergic agonists, will relax the bronchial smooth muscle, helping to open the airway, decreasing the obstruction, stimulating the fight or flight response. Clients should only take the prescribed number of doses per day. This is not a case where more is better. Anticholinergics are another group of these bronchodilators. They will relax the muscles around the larger airways or the bronchi. Leukotriene receptor antagonists are another class of drugs that may be used if more typical medications are not effective, meaning that we have tried using a bronchodilator, we have tried using an anticholinergic, we have tried using an anti-inflammatory. Nothing seems to be controlling these symptoms, so doctor will go to a leukotriene receptor antagonist. Ladies and gentlemen, please take note. Ladies and gentlemen, please continue to listen up. Leukotriene receptor antagonists are not steroids. They will inhibit the leukotriene-mediated inflammatory response. So they are not an antihistamine, but they will act like an antihistamine in the fact that they will stop the trigger from releasing the histamine to further the exacerbation. Medications will also fall into two categories: long-term control medications and then what we call rescue medications. And these rescue medications are often used for mild cases, meaning that if I happen to exercise a lot, if I'm a weekend warrior, so if I'm really going to work myself hard this weekend, I'm going to run, I'm going to ride my bike, maybe I'm doing a hike, I'm going to take my inhaler with me. So I'm going to use my inhaler should I start to feel chest tightness. Long-term control medications are used daily, regardless of the symptoms, to achieve and maintain control. The most effective long-term control medications are inhaled anti-inflammatories. Ladies and gentlemen, please take note. So rescue drugs are those medications that are used once an asthma attack has started, and we can call this an acute exacerbation. These are usually short-acting bronchodilators. They're going to work very quickly to open up my chest. Short-acting beta-2 antirenergic agonists are the gold standard because they are the most effective, and they should be used for acute exacerbation only. Oral corticosteroids such as prednisone may also be used in an acute exacerbation. So as the attack will subside, these drugs are tapered off. They are not to be discontinued abruptly. So, complications of asthma. Status asthmaticus is an acute exacerbation that is unresponsive to the typical rescue treatment with bronchodilators, even after repeated frequent doses. It can vary from mild to severe with bronchospasm, inflammation, and then excessive mucus production with mucus plugs. Clients will report chest tightness, wheezing, a dry cough, shortness of breath, and severe respiratory distress. This will result in carbon dioxide retention, hypoxemia, and then ultimately respiratory failure. Typical triggers include the recent onset of a viral respiratory illness, exposure to a potent irritant or an allergen, or exercising in the cold. A life-threatening emergency requiring prompt medical response. Treatment will include oxygen, IV fluids, systemic bronchodilators, and steroids to open the airways and then decrease inflammation. Endotracheal intubation may be necessary in severe cases until symptoms are under control. So, ladies and gentlemen, please listen up and take note. On page 526, there is a safety alert, and you will take note of that safety alert. So, nursing management of asthma. The symptoms the client will exhibit during an asthmatic attack are related to the airway obstruction, and this will include dyspnea, use of accessory muscles for respiration, wheezing, elevated pulse, elevated blood pressure, increased anxiety, the inability to lie flat, the inability to talk in complete sentences, and decreased peak flow readings. So, we are going to assess because we are nurses. We always start with vital signs. We're going to look at the pulse rate, the temperature, the respiratory rate, the peak flow measurement. Increased pulse rate may be a sign of poor oxygenation or anxiety because of what the patient is undergoing, or it could be a side effect of the treatment with the bronchodilator. Increased temperature is a sign of infection. Respiratory rate greater than 30 breaths per minute is due to increased anxiety, and then the increased work of breathing due to the bronchial constriction. So your patient is going to want to breathe faster because they will believe that if I breathe faster, I will get more air into my lungs and I will feel better. And that is not the case. Peak flow values will indicate the severity of the asthma attack and then help monitor recovery. So, ladies and gentlemen, listen up, and listen up again. Use of accessory muscles. Use of accessory muscles will demonstrate muscle fatigue because the chest muscles are getting tight. So now the patient is going to start belly breathing. So instead of their chest rising and falling, what we're going to see is their abdomen rising and falling. So they may want to be in a position known as the tripod position or a semi-Fowler's position. The client may assume the tripod position to decrease the work of breathing because their chest is going to be hunched over a table or a pillow. It decreases the length of the chest, and so it will make it easier for them to breathe. We are going to monitor dyspnea and then oxygen saturation. Oxygen saturation less than 90% indicates significant oxygenation problems. Hypoxemia will cause restlessness, anxiety, increased blood pressure, and an increased pulse rate. Ladies and gentlemen, please continue to listen up. That arterial blood gas. As respiratory difficulty increases, respiratory acidosis will develop, and this is what we call an elevated CO2. We are holding on to carbon dioxide, and then a decreased O2, meaning that the oxygen level in my body is decreasing. I have more carbon dioxide than I do oxygen. And this will indicate hypoxemia. My patient is now in what we call respiratory acidosis. They are in an acidotic state and they are at risk for respiratory arrest. Breath sounds, the presence of wheezing will indicate narrowing of the airway. First, we will hear expiratory wheezing, then inspiratory wheezing. Inaudible or diminished breath sounds will signify a decrease in the movement of air due to increased obstruction or respiratory exhaustion. My patient is just tired. So, we will also monitor for the ability to speak in full sentences. Inability to speak in full sentences is an indicator of respiratory distress. We are going to monitor the cough, the level of consciousness. Changes in level of consciousness are indicators of hypoxemia, no oxygen getting to the brain. We also know that if it happened once in the nursing world, in the medical world, my patient is at risk for it happening again. So if my patient has previously been intubated, chances are it may have to happen again. So the need for intubation in past asthma attacks is an indicator of the patient's severity level. And then actions. We are going to provide oxygen. We are going to administer those bronchodilators as doctor has ordered. We are going to administer anti-inflammatory medications and those steroids as ordered. We are going to administer anticholinergics as doctor has ordered. Anticholinergics will relax the muscles around the larger airways or the bronchi. And then teaching patient education. We are going to provide the client with an individualized written action plan that will include daily management of asthma and how to recognize symptoms of exacerbations. Control over asthma over time will require regular assessment and then consistent management. And then patient education with that aero chamber. So ladies and gentlemen, please listen up, and then listen up again. On page 525, box 26.1, patient education for the peak flow meter. You are going to take note of that. And on page 532, box 26.3, patient education for the aero chamber. You are also going to take note of that. So, more nursing interventions for asthma. We are going to talk to them about avoiding risk factors. We are going to educate them on pursed lip breathing. Pursed lip breathing will keep the airway open longer and prolong exhalation, allowing increased time for oxygen and carbon dioxide exchange. And then medication education. Education on the peak flow meter. Monitor the pulmonary status to establish a baseline and then reassess during an acute exacerbation to determine the severity of respiratory distress. We are going to talk to our patient about smoking cessation, proper inhaler technique, and then cleaning their respiratory equipment. The peak flow meter, the nebulizers, and then the metered dose inhalers must be kept clean to prevent infection. So, how do I know? How do I know that I've done a good job taking care of this patient that has asthma? A well-managed asthmatic client has decreased visits to the emergency department and will use his rescue medications less often. The client has minimal symptoms during the day and the night. And then to accomplish this, the client has adequate knowledge to manage his disease. The client will cease smoking or at least decrease the amount that they smoke, make the home and environment as allergy-free as possible. They will monitor their peak flow readings and adhere to the asthma management plan. By following the treatment plan, the client will delay the progression of asthma and will have fewer exacerbations and longer periods of time when they are asymptomatic. So, ladies and gentlemen, we are talking about chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease, otherwise known as COPD, is composed of two diseases, actually, emphysema and then chronic bronchitis. And it is the fourth leading cause of chronic morbidity and mortality in the United States. So, the prevalence is higher among women than men, and cigarette smoking, no shocker here, is the primary cause. Approximately 80 to 90% of COPD deaths are caused by smoking. Some other risk factors include occupational dust and chemicals, outdoor air pollution, and then secondhand smoke. So, the pathophysiology of COPD. It is a disease that is characterized by airflow limitations. The airflow limitation is progressive and is associated with an abnormal inflammatory response of the lung to noxious particles or gases. It is composed of two pulmonary diseases, emphysema and chronic bronchitis, and both of these diseases will cause obstruction to the airflow, but in different ways. So, chronic bronchitis will affect the small airways and is defined as the presence of cough and sputum production for at least 3 months in each of the 2 consecutive years. It is caused by inflammation of the bronchi and the bronchioles. The inflammation will cause an increase in the production of mucus cells, which will produce a large amount of thick mucus. The walls of the bronchus will thicken and then cause airway obstruction. Smaller airways are usually affected before the larger airways. So emphysema is caused by the destruction of the alveoli. The client with emphysema will lose lung elasticity and then develop hyperinflation of the alveoli. Carbon dioxide cannot leave the alveoli and oxygen cannot enter, and this will result in an ineffective exchange of oxygen and carbon dioxide. So the client will have carbon dioxide retention and then chronic respiratory acidosis. Increased work of breathing and shortness of breath. This is evidenced by use of the accessory muscles and the client assuming what we call the tripod position to help ease the work of breathing. And ladies and gentlemen, please listen up. One of the hallmark signs of a COPDer is that they will appear to have a barrel chest. They may have a reddish complexion and appear to be puffing, and we call these the pink puffers. And so the pink puffers are the population that will have emphysema. The manifestations of chronic bronchitis are different from the manifestations of emphysema. So because of the hypoxemia, clients will appear cyanotic, otherwise known as blue bloaters, and have excessive mucus production with a productive cough. The earliest symptom is a morning cough with clear sputum. Ladies and gentlemen, please take note of this. Disease is characterized by exacerbations that can occur after exposure to pollutants, such as smoke or respiratory infections, such as a cold or flu. An exacerbation is defined as a change in the natural course of the disease, evidenced by a variation from the client's baseline day-to-day symptoms of dyspnea, cough, and or sputum. So typically, an acute onset may warrant a change in their regular medications. Some warning signs of an exacerbation will include increasing shortness of breath, wheezing, more frequent or severe cough, anxiety, problems with sleep, and then a decreased appetite. Ladies and gentlemen, please listen up, and then listen up one more time. The diagnosis of COPD is based on the patient's history, physical assessment, and spirometry. The client will report progressive shortness of breath. Ladies and gentlemen, please take note. Chest x-ray is typically done to rule out other causes of respiratory distress. Spirometry is measurement of the lung volumes and airflow. There are two tests done by spirometry, and they are forced vital capacity, which we call FVC, and then the forced expiratory volume in 1 second, and that is the FEV1. So forced vital capacity, again, we can also call it FVC, is the maximum volume of air that can be exhaled during a forced expiration. FEV1 is the volume of air that is expired in the first second of maximal expiration after a maximal inspiration. It is a measurement of the lung's ability to empty quickly. So diagnosis is based on both the value of the FEV1 and then the FEVC. Clients with COPD will show a decrease in both the FEV1 and the FEVC. So again, COPD is a progressive disease. As progression occurs, the FEV1 and the FVC will deteriorate and exacerbations become more frequent and then life-threatening. Severity and progression is indicated by the degree of abnormality of the tests. So, treatment of COPD. The management plan for COPD will have 4 goals: assess and monitor the disease, reduce the risk factors, manage stable COPD, and then manage exacerbations. Assessment includes regular pulmonary function tests and chest x-rays with an exacerbation to identify other thoracic abnormalities or progressive changes within the structure of the lungs. Treatment includes pulse oximetry to determine the severity of hypoxemia during an exacerbation. So treatment also includes ABGs to measure oxygenation, ventilation, or the lung's ability to clear carbon dioxide as evidenced by CO2, and then acid-base balance. ABGs also help identify the client's response to oxygen therapy and then medications. So sputum cultures are assessed to identify organisms causing an infectious trigger to an exacerbation. And then reducing risk factors will include decreasing or eliminating exposure to chemicals, dust, and air pollutants, especially smoke. So the single most significant strategy is smoking cessation. Managing stable COPD will include health education regarding the risks and the warning signs of an exacerbation, oxygen therapy, moderate exercise as tolerated, and the mainstay of medical management, which would be medications. The cornerstone of pharmacological management are bronchodilators, beta-2 adrenergic agonists, and anticholinergics used individually or in combination on an as-needed or regular basis to control symptoms. So, a way to evaluate the effectiveness of treatment and to determine a course of therapy is to give a bronchodilator treatment after the initial spirometry and then repeat the test. This will help to determine how the lungs respond to the bronchodilator or how the pulmonary obstruction is reversed with the medication. So medication management will progress as the disease progresses. So we will start with inhaled bronchodilators on an as-needed basis. As the disease worsens, we can move on to long-term bronchodilators. Inhaled glucocorticoids are added when and if the patient experiences more frequent exacerbations. So, identifying and quickly managing exacerbations is essential because they can dramatically impair pulmonary function and then speed up the disease progression. Inhaled bronchodilators and oral glucocorticoids are utilized as well as antibiotics if the cause of the exacerbation happens to be an infection. So, some complications of COPD. A complication of COPD is what we call secondary spontaneous pneumothorax. This will occur in patients with an underlying lung disease. It is caused by the rupture of the overinflated alveoli, and sometimes we call these blebs. Patients will present with dyspnea and chest pain. Treatment priorities will include supplemental oxygen and chest tube placement to remove air from the pleural space to allow re-expansion of the affected lung. So, ladies and gentlemen, listen up, and then listen up one more time. The clinical manifestations presented by the client are due to airway resistance, increased work of breathing, and increased sputum production, and therefore they include a cough, sputum production, dyspnea, the use of accessory muscles, wanting to be in the tripod position, and the inability to talk in full sentences. So, pursed lip breathing will be part of nursing management. Anxiety, managing that anxiety will also be part of nursing management. Some interventions will include assessments, and we will start with vital signs. That increased temperature will be a sign of an infectious trigger. We are going to monitor the dyspnea and oxygen saturation. An SpO2 of less than 90% will indicate significant oxygenation problems. So, ladies and gentlemen, listen up, and then listen up one more time. The respiratory rate. We need to monitor the respiratory rate to avoid hypoventilation. The respiratory drive in COPD is hypoxemia, not hypercapnia. So if the client receives too much oxygen, it may blunt his respiratory drive. Respiratory effort in a client with COPD is triggered by the decrease in the oxygen level, not an increase in carbon dioxide. So therefore, too much oxygen may cause a decreased respiratory effort. So therefore, oxygenation for this population should be no more than 1 to 2 liters per minute. Ladies and gentlemen, please take note. Weight. We are going to monitor their weight to identify nutritional deficiencies. With prolonged increased work of breathing and decreased energy, the ability to eat will decrease. And then the breath sounds. The presence of crackles and wheezes may indicate airway obstruction, so crackles will indicate the premature closing of the airways. Ladies and gentlemen, please listen up, and then listen up one more time. Pursed lip breathing. Pursed lip breathing will keep the airways open longer and prolong exhalation, so allowing for increased time for oxygen and then the carbon dioxide exchange. Also, the cough. Cough is a cardinal sign of pulmonary disease. So, on page 536, box 26.4, it will discuss pursed lip breathing, and you will know that information. So, nursing actions. We are going to administer bronchodilators as ordered. Bronchodilators are bronchial smooth muscle relaxants that will help to open the airway, and we will provide oxygen to increase the SpO2 to 90%. We are going to provide small, frequent meals with dietary supplements. Ladies and gentlemen, please listen up, and then listen up again. Small, frequent meals will take less energy to consume and avoid excessive pressure on the diaphragm that is associated with a large meal. And then adequate fluid intake. We want this fluid intake to be at least 2 to 2.5 quarts a day. We are going to position this patient in semi-Fowler's position. The semi-Fowler's position will increase oxygenation by allowing the adequate lung expansion. So, ladies and gentlemen, listen up, and then listen up again. Teaching breathing techniques such as that pursed lip breathing is very important. And then pacing of activities. Activity conservation will decrease the work of breathing and then conserve their energy. Also, smoking cessation program. Smoking cessation is key to managing COPD and can change the course of the disease. And then nutritional needs, those small, frequent meals. Ladies and gentlemen, please take note. Please continue to listen up. Medication regimen, knowledge regarding medications and their use, and then, ladies and gentlemen, vaccine prophylaxis. Pneumococcal vaccination and an annual flu vaccine will decrease the risk of disease exacerbations that are due to respiratory infections. So, recognition of symptoms of the exacerbation. The client and the family should be aware of signs that will signify the client's respiratory system is becoming impaired. And then coping strategies. The client and the family should be aware of the lifestyle changes that may occur because of this COPD. So these include an inability to maintain an active lifestyle, an inability to care for oneself, depression, denial, and social isolation. Strong support and effective coping strategies are essential to manage the lifestyle changes. So, ladies and gentlemen, please listen up, and then listen up one more time. Evaluating care outcomes of COPD. How do I know that I've done a good job taking care of this population? A well-managed client with COPD will have decreased visits to the emergency department and hospitalizations. The client has adequate knowledge to manage his disease. There is medication compliance and avoidance of people with colds or flu that may increase the risk of exacerbation. And then smoking cessation is successful and healthy dietary habits are maintained by eating small, frequent meals. So, moving on to lung cancer. The American Cancer Society indicates lung cancer is the second most common cancer in both men and women. Also, the number one cancer killer in the United States for men and women. And ladies and gentlemen, please take note that overall, women will have a lower rate than men. So, if diagnosed with stage 1A lung cancer, the survival rate is 49%. If diagnosed with stage 4 lung cancer, the survival rate is only 1%. So, when diagnosed with stage 4 lung cancer, the disease has already spread to lymph nodes and then other organs. It is most prevalent in persons over age 65, and the major cause for approximately 90% of the cases, and the most preventable is, I know this is going to shock you, but it is smoking. So, lung cancer risk will increase as the number of cigarettes smoked and the length of time spent smoking increases. However, ladies and gentlemen, please listen up and please take note. The risk factor of someone who quits will be dramatically less than someone who continues to smoke. Other risk factors will include secondhand smoke, occupational pollutants, and asbestosis. So the pathophysiology of lung cancer, it is caused by the uncontrolled growth of abnormal cells in the lungs. The two major types are non-small cell and then small cell. Non-small cell cancer represents approximately 85% of lung cancers and will consist of 3 different types of cells. There are squamous cell, adenocarcinoma, and then large cell carcinoma. 5-year survival rate for those diagnosed with non-small cell cancer if it is diagnosed early. Small cell cancer is also called oat cell, and this represents approximately 15% of lung cancers. It will grow quickly and metastasize to other organs in the body just as quickly. It is independent of stage at diagnosis, so the survival statistics are very poor. Only approximately 5 to 10% of those developing small cell cancers will survive for 5 years. So the clinical manifestations of lung cancer, they are not typically apparent early in the disease, but will become apparent as the disease advances. It will include a new cough that does not go away, or changes in a chronic cough, hemoptysis, shortness of breath, wheezing, hoarseness, and then finally chest pain. Headache and bone pain may also be present. Weight loss is very common, and as would be expected, the symptoms become progressively worse as the disease progresses. So, diagnosis is done through several methods, the chest x-ray, and then now, ladies and gentlemen, listen up, and then listen up one more time. CT scan of the chest. This is used to evaluate and localize tumors. It can also detect distant tumor mets and evaluate tumor responsiveness to treatment. Ladies and gentlemen, please take note. And then sputum for cytology, and then bronchoscopy. We can also do a PET scan, bone and abdominal scans, and a mediastinoscopy. Chest x-ray or CT scan of the chest may identify a pulmonary lesion, sputum for cytology to identify specific tumor cells. Bronchoscopy or mediastinoscopy will allow direct visualization of the tissues to aid in the diagnosis of lung cancer. Bronchoscopy is the assessment of the larger airways, the trachea and bronchi, through a large scope inserted through the mouth or the nose. A mediastinoscopy is a surgical procedure that will allow for direct visualization of the mediastinum. And then a scope will be inserted through an incision in the chest that will allow for direct examination and collection of samples for biopsy. Bone and abdominal scans are done to look for metastatic lesions. The PET scan can detect areas of increased metabolic activity as it occurs with rapidly dividing cancer cells. So, non-surgical management of lung cancer. Treatment for lung cancer is multidisciplinary and is dependent upon the type, the size, the location, and then the stage of the tumor. It will typically consist of a combination of surgery, radiation, and chemotherapy. Pain management is also an important focus in treatment. The chemotherapeutic agent used to treat lung cancer is dependent upon the type of the tumor that is involved. So it can sometimes be given before surgery to shrink the tumor to aid in resection, and we call this neoadjuvant therapy. It can be used as adjuvant therapy after surgery to kill any remaining cancer cells, as it may be the main treatment option for more advanced cancers, or if the client is too ill for surgery. Radiation can be used if surgery is not an option because the tumor cannot be removed. Radiation also can be used to shrink the tumor before surgery or after surgery to kill any remaining cancer cells. Radiation can also be used palliatively to relieve symptoms or for pain control. Pain control is a major factor in lung cancer management. A pain relief ladder has been developed by the World Health Organization, and it can be used as a guideline for pain management. Step 1 will involve the use of non-opioid analgesics, such as acetaminophen or an NSAID, and we can use this for mild or moderate pain. Step 2 would consist of a moderately potent opioid, such as codeine, hydrocodone, and oxycodone, plus a non-opioid for persistent pain that is not controlled by step 1. Step 3 includes the use of stronger opioids such as morphine, fentanyl, plus a non-opioid for uncontrolled or severe pain. At all levels, adjuvant or additional drugs should be given to relieve client anxiety. And then pain medication should be given around the clock rather than on demand to avoid peaks of pain. Palliative care services are appropriate to consider from the diagnosis of a life-threatening illness, such as lung cancer, through the course of the disease. Palliative care will improve the quality of life of clients and their families. Palliative care can also help in management of other distressing and debilitating symptoms, such as shortness of breath and then nausea and vomiting. Surgical management of lung cancer. Surgery is the preferred treatment if there is no metastasis. It is primarily used for non-small cell tumors, and there are several types of pulmonary surgery depending on the tumor site and the tumor size. A lobectomy is the removal of the entire lobe of the lung. Pneumonectomy is the removal of the entire lung, and the wedge resection is the removal of a small section of the lobe of the lung. So, nursing management of lung cancer. The client with lung cancer will present with the following characteristics as a result of abnormal cell growth and tumors in the lungs causing impaired chest movement and air exchange. So they will include a persistent cough, dyspnea, wheezing, and hemoptysis, chest pain, and then frequent episodes of pneumonia or a bronchitis. Excuse me. Nursing interventions for lung cancer. We are going to assess. We are going to start with temperature. Increased temperature will be a sign of infection. Oxygen saturation. Decreased SpO2 is due to poor gas exchange. An SpO2 of less than 90% will indicate significant oxygen problems. And then appetite and weight. Appetite may be decreased because of the side effects of chemotherapy or the loss of energy due to the increased work of breathing. So monitoring weight will identify any nutritional deficiencies. Breath sounds. The presence of wheezes may indicate airway obstruction. Rhonchi will indicate increased secretions in the upper airways. Cough. Cough will indicate an irritation of the tracheobronchial tree. And then pain. Pain will increase respiratory rate, their anxiety, and it will decrease their quality of life. So, actions for lung cancer. We will administer medications as ordered, pain medications and anti anxiety medications. Pain and anti anxiety medications will provide relief from both pain and anxiety, allowing better relaxation. And bronchodilators. Bronchodilators, bronchial smooth muscle relaxants will open the airway and decrease the work of breathing. We will provide oxygen. And ladies and gentlemen, please listen up one more time. Provide small, frequent meals with dietary supplements. Dietary supplements will increase nutritional caloric intake, providing energy for the work of breathing. Ladies and gentlemen, please take note. And we will position them in a semi-Fowler's position. Ladies and gentlemen, listen up, and listen up again. Breathing techniques. Controlled breathing techniques will help to increase the clearance of sputum and reduce the sense of breathlessness. Pursed lip breathing will encourage the exchange of oxygen and carbon dioxide. Pacing activities conserves energy and reduces the work of breathing. And then smoking cessation. Smoking cessation can change the course of the disease process. Ladies and gentlemen, please take note. And please continue to listen up. Nutritional needs. Small, frequent meals will decrease the work of breathing with less impact on the diaphragm. Medication regimen. Knowledge regarding medications and their use, such as proper use of inhalers, increase the ability to manage the disease, and the use of pain medications around the clock. So, how do I know? How do I know that I've done a good job taking care of this patient with lung cancer? A well managed client with lung cancer has their pain under control, sufficient appetite and weight, and adequate oxygenation. This is managed through around the clock pain medication, small frequent meals, and appropriate use of oxygen and bronchodilators, and then provide regular follow up and palliative care referrals because this is essential to maintain optimal quality of life. So, moving on to infectious respiratory disorders. The respiratory tract maintains a persistent interface, thank you, with the external physical movement, resulting in a high degree of direct exposure to microorganisms. The respiratory tract is a common site of infection by pathogens. There is a sense of complex, comprehensive, and efficient protective and defense mechanisms against harmful pathogens for both the upper and the lower respiratory tracts. So, the establishment of a respiratory tract infection. So, in order for a respiratory infection to be fully established in the lower respiratory tract, the following barriers must be avoided and some conditions met. Avoidance of trapping in the mucociliary layer of the upper respiratory tract, and then avoidance of the phagocytotic action of the alveolar macrophages in the lower respiratory tract. Infectious organisms must be airborne and could remain virulent while in the air. and there must be enough infectious organisms inhaled and deposited on susceptible tissues within both the upper and lower respiratory tracts, preventing innate protective mechanisms from functioning effectively. So, the inflammatory response of the respiratory tract. Once pathogens have been established in the respiratory tract, an inflammatory response is initiated. Neutrophils, which we know are white blood cells, are recruited to the infected alveoli along with other immune cells and serum components. Accumulation of fluid and the exudate will provide the perfect medium for the proliferation of the infecting organism and assisting with movement to other nearby alveoli. Fluid and exudate-filled alveoli are prevented from effective gas exchange at the alveolar capillary level, and this will produce varying degrees of hypoxia depending on the severity of the infection. So we are going to talk about the flu, influenza. It is a highly contagious infection that is rapidly spread from one individual to another. Outbreaks are tracked, recorded annually, and reported by the Centers for Disease Control and Prevention. Localized outbreaks that affect more than the expected population are called epidemics, and these occur at varying intervals, usually every 1 to 3 years. Substantial morbidity and mortality occur predominantly among those who have underlying comorbid medical conditions, who are of the very young or the advanced age. Human influenza viruses are divided into 3 types, designated as A, B, and C, but for our purposes, we will only discuss A and B. Influenza types A and B are responsible for epidemics of respiratory illness that occur mostly during the winter months and are often associated with increased hospitalizations and deaths. Most extensive and severe outbreaks are from influenza A. Seasonal mutations of the viruses will cause the emergence of a new and very different influenza virus, and can contribute to a new pandemic. These mutations will allow the virus to escape the immune system surveillance of its host, making individuals susceptible to mutated influenza infections throughout their lives. So, efforts to control the impact of influenza are focused on types A and B. Influenza C typically causes either no symptoms at all or a very mild respiratory illness. It is not associated with the occurrence of epidemics and does not have the serious public health concern that is associated with influenza A and B. So, the pathophysiology of influenza, the primary event that initiates an influenza infection is the aerosolization of small droplets from an infected individual sneezing or coughing or by direct contact with fomites that are inhaled and become deposited on the upper respiratory tract epithelial cells. So, over a period of approximately 4 to 6 hours, these infected cells will reproduce and spread the virus to other respiratory cells, extending the infection throughout the respiratory tract. The incubation period, meaning the incubation period. So, this is the time, the initial droplet inhalation to symptom development, and this can last approximately 18 to 72 hours. The severity of the symptoms and subsequent illness is dependent on the number of viruses shed during the replication phase and the number of respiratory cells that are affected. Virus shedding usually ends 2 to 5 days after symptoms first appear. So it is important to remember that individuals are infectious for up to 7 to 10 days. So, on page 462, table 24.1, risk factors for influenza infections. Ladies and gentlemen, you will know that table. So, some clinical manifestations of influenza, more severe than those of a cold, and they will come on more quickly, and they will include fever, headache, a sore throat, severe nasal congestion, cough, malaise or muscle aches and pains, and then malaise. Malaise is the general feeling of being unwell and increased fatigue. So, the management of influenza, how is it diagnosed? The diagnostic gold standard is a sampling of respiratory secretions for viral culture. The most significant drawback to this method is that viral cultures can take up to 10 days to provide confirmation. So, in emergency departments and outpatient clinics, the most utilized tests are called rapid influenza diagnostic tests. Identification can be made in less than 30 minutes via a nasopharyngeal or a throat swab or a nasal washing and an aspirate. Sensitivity and specificity of RIDTs can be variable depending on the manufacturer's test used and the type of influenza virus circulating during a specific outbreak. A negative RIDT does not necessarily mean that there is no influenza infection. It could be a false negative test. Clinicians, therefore, should not make a diagnosis solely based on the test result, but should also consider the client's symptoms and their history, and then rely on their clinical judgment. Circulating antibodies can be detected in the blood of individuals with an influenza infection within 2 weeks after the initial infection. So, treatment of influenza. Treatment is directed primarily toward prevention by annual vaccination, inoculation by inactivated influenza viruses that were identified as causing outbreaks the preceding year can provide up to 80% protection from the projected upcoming year's virus. Side effects from vaccination will occur infrequently and consist of low-grade fever and then soreness at the injection site. Individuals who have an allergy to eggs should not receive this form of vaccine because of an inactive egg ingredient of an egg protein. So, alternative forms of vaccine without this protein can be available. The most appropriate time of year for vaccination is in the early fall before the flu season actually begins. So, medications for influenza. Medications are directed toward the relief of symptoms. Antipyretics, analgesics for fever and aches, adequate fluid intake to avoid dehydration, and rest are typically prescribed. For more serious forms of influenza or widespread local outbreaks, several antiviral medications are available for prophylaxis or for treatment. So, the decision to treat flu symptoms utilizing antiviral medications is made based on the severity of the presenting symptoms, the client's overall health status, and the presence of any significant underlying comorbid risk factors. The administration of antiviral medications does not cure the flu. Further viral replication within the respiratory tracts will be impaired. The best results are achieved when antiviral medications are initiated within 24 to 48 hours of symptom onset. So, complications of influenza. Primary influenza viral pneumonia is the least common but severest complication and occurs more frequently in individuals over the age of 65 years with or without chronic underlying illness. It is marked by progressive shortness of breath, persistent fever, and cardiovascular compromise. Dyspnea with negligible sputum production that may be visibly blood streaked is also associated with the onset of a secondary bacterial pneumonia. Frequent bacterial organisms linked to secondary pneumonia are strep, Staphylococcus, and Haemophilus influenzae. These organisms are resident normal flora within the nasopharynx that become pathologic when the respiratory defenses are altered. Secondary bacterial pneumonia classically presents as improvement in viral symptoms followed by an acute recurrence of symptoms with purulent nasal and tracheal secretions. Sinus and middle ear secondary bacterial infections may also accompany an influenza viral illness. So, awareness of clinical manifestations and predictors of increased mortality is essential for treatment. So, ladies and gentlemen, listen up, listen up, listen up one more time. Clinical predictors will include altered mental status, a respiratory rate greater than 30 breaths per minute, hypotension, tachycardia, an elevated CO2 level, because this will lead us to respiratory acidosis. Clinical manifestations observed in the client with influenza, cough, a headache, nasal congestion, sore throat, and fever are typically the result of the inflammatory response once the virus has invaded the respiratory epithelium. So, some nursing interventions for influenza. We are going to assess, we're going to look at our patients. So, sudden onset of fever, chills, muscle aches, and fatigue in a generally ill appearing client. So, our client is going to look like they don't feel well. Neurological function, agitation, restlessness, anxiety, lethargy, and fatigue are the result of decreased tissue perfusion from altered alveolar gas exchange. Then, ladies and gentlemen, please listen up, and listen up right now. Tachypnea, the body's first compensatory mechanism to decreased oxygen delivery, is an increased respiratory rate and depth. So, we are going to focus on deep breathing, we are going to elevate the head of the bed, and we are going to make sure that they are hydrated. Ladies and gentlemen, please take note. And then tachycardia. Tachycardia will be the body's second compensatory mechanism for a continued impairment of oxygen delivery to raise the heart rate. So, decreased oxygen saturation, impaired gas exchange at the alveolar level will result in hypoxia and therefore possible intubation for my patient. Fever will occur as a part of the inflammatory response. We are going to assess breath sounds. Adventitious breath sounds such as wheezing, bronchi, crackles, and rales may be audible on lung assessment from fluid and exudates filling the alveoli. And then the cough, nasal congestion, sneezing, and rhinorrhea. Primary viral pneumonia from influenza can cause coughing that will last up to 2 weeks. Purulent nasal discharge and sputum will indicate a secondary bacterial infection. Peripheral pulses and skin temperature and color. Diminished tissue perfusion causes blood to be shunted away from peripheral areas to the main core body organs, so peripheral pulses will diminish and skin will become moist and pale. And then laboratory values. Ladies and gentlemen, please take note right now that arterial blood gas. Primary respiratory infections will cause respiratory acidosis. During respiratory acidosis, there is a decreased pH, increased carbon dioxide level. Some nursing actions for influenza. We will initiate appropriate isolation procedures, droplet and contact precautions to avoid viral transmission Thank you so much. Administer humidified supplemental oxygen. Thank you. Yes, I will. Improvement in oxygen delivery, reversing hypoxia, and maintaining moist respiratory mucosa is essential to avoid complications. And then administer antipyretics as ordered and indicated. Fever reduction can reduce hyperdynamic effects on the respiratory and cardiovascular systems and increase client comfort. Administer analgesics as ordered and indicated. Pain relief can increase comfort and allow for mobilization and effective coughing, expectoration of respiratory secretions. And then administer those antiviral medications if they are ordered or indicated. Early administration of antiviral medications, meaning within 24 to 48 hours of symptom onset, will offer the most favorable outcome for shortening the severity and duration of symptoms and decreasing the incidence of respiratory complications in high-risk client populations. So, ladies and gentlemen, listen up, and listen up again. So, position the client in semi to high Fowlers with the head of the bed raised to 30 degrees. Sitting up or elevating the head can provide for release of nasal drainage, promoting optimal lung expansion, preventing atelectasis, and preventing aspiration that can lead to secondary bacterial pneumonia. And provide adequate fluid intake. Obtain those cultures, nasal swabs, throat swabs, sputum, blood, and urine before we administer any antiviral medications. So, patient education for influenza, we will practice and tell our patient to practice good hand hygiene. Hand washing is essential to prevent spreading of the virus to others. We will disinfect frequently used objects and surfaces, avoid contact with others for up to 10 days after the first symptoms appear, for at least 24 hours after the fever has gone. Because please remember that viral shedding will continue from 10 days up to several weeks. Report any worsening shortness of breath, change in amount, color, and viscosity of pulmonary secretions, and recurrent fever. Viral infections can be mild at first, rapidly progressing to primary viral pneumonia or secondary bacterial pneumonia. And then, ladies and gentlemen, please take note. Maintain adequate fluid intake. Insensible losses from tachypnea and fever can lead to dehydration and thickening of those pulmonary secretions with difficult expectoration. So we are going to perform medication teaching for expected desired effects, potential side effects, and then expected duration of treatment. So we are going to tell the patient to take all antiviral medications if they are prescribed. Make sure to take them all, even if they begin to feel better. Educate that the addition of antibiotics may become necessary for the occurrence of a secondary bacterial infection. Antiviral medications do not cure the flu. They will just shorten the duration and severity of symptoms, and it may prevent serious complications. Be sure to get the flu vaccine every year and strongly recommend this to clients and their families, as vaccination is the best method for preventing the flu. And then how do I know? How do I know that I've done a good job, taking care of this patient with influenza? Influenza may be avoided with the flu vaccine. Mild cases usually resolve without complications. Indicators of resolution are vital signs within the client's normal limits. Absence of fever for 24 hours after completion of antiviral medications if they were prescribed. Even and unlabored respirations. oxygen saturation above 92%, or returning to the client's baseline without oxygen administration, the absence of nasal drainage, no sputum production, the absence of cough, and a clear chest x-ray. So pneumonia. Pneumonia can occur at any time and individuals of any age. The National Center for Health Sciences will report that older individuals over those of the age of 65 are at a higher risk of death from respiratory infections, and nearly 90% of deaths were in this age group. So the clinical manifestations of pneumonia, the clinical manifestations produced by the inflammatory response can vary from mild to severe and include fever. Ladies and gentlemen, please take note. Tachypnea and dyspnea, please take note. Tachycardia, chills, cough, productive or non-productive, and then pleuritic chest pain. Ladies and gentlemen, please take note of fatigue, malaise, arthralgia, and then in more severe forms, additional manifestations may be, ladies and gentlemen, please take note, purulent or blood-streaked sputum, as well as hypotension and dysrhythmias. So, awareness of the clinical manifestation and predictors of increased mortality is essential to help ensure the speedy identification and treatment. The Infectious Diseases Society of America and the American Thoracic Society guidelines validated clinical predictors of increased mortality and morbidity from severe infectious pneumonia, including altered mental status and then a respiratory rate greater than 30 breaths per minute. Hypotension. Hypotension is defined as systolic blood pressure less than 90, heart rate greater than 125 beats per minute, body temperature less than 95 degrees or greater than 104 degrees, an arterial pH less than 7.35, a serum sodium level less than 130, and hematocrit less than 30%. A PaO2 less than 60 on supplemental oxygen greater than or equal to 40%. And then the presence of pleural effusion on a chest x-ray or a CT scan. So the management of pneumonia, how is it diagnosed? Diagnosis is based on laboratory and imaging studies. Laboratory findings will include an elevated WBC count with elevated bands on the differential, elevated C-reactive protein level, an accurate, sensitive, and historically used test to detect the presence of inflammation and infection. And then ABGs will typically reflect a primary respiratory acidosis with hypoxemia. So there will be an elevated CO2, a decreased O2, and a decreased pH. So sputum cultures will reveal a preliminary category of the offending organism by gram stain and confirm the specific organism after 24 to 48 hours of incubation in the lab. Imaging studies will reveal a chest x-ray that may or may not allow to show infiltrates and can be up to 72 hours behind in revealing an infectious process. CT scans of the chest may better demonstrate consolidation, meaning this is the solidification, of the lung tissue, and the presence of a pleural effusion. So again, prompt diagnosis is essential in providing timely and effective treatment. Treatment is dependent upon the type of pneumonia and early diagnosis, and then the overall health of the client. So if uncomplicated, this can be effectively treated in the outpatient setting. More severe cases, however, require hospitalization and supportive care. Due to the possibility of hypoxia Administration of oxygen to reverse or prevent hypoxia is an essential first step. Ensuring adequate hydration is also an important intervention to support the client's cardiovascular status and assist in thinning those respiratory secretions for easier expectoration. So medications for pneumonia, those bronchodilators, bronchodilator therapy with albuterol. Albuterol is a short-acting selective beta-2 adrenoreceptor agonist. Or Combivent. Combivent is a slow-onset anticholinergic agent, and these can be delivered either by aerosol nebulation or by metered dose inhaler, which will open swollen and narrowed airways and then promote the ease of breathing. Antibiotic therapy, which is the definitive treatment, is based on the offending organism, and initially a broad-spectrum antibiotic will be initiated. So complications of pneumonia, severe MRSA CAP can lead to a necrotizing bacterial pneumonia requiring hospitalization. A necrotizing pneumonia results in fibrosis and scarring of the lung tissue. Pulmonary fibrosis and pulmonary hypertension from severe pulmonary infections can impair lung function after the respiratory infection resolves. Acute meningitis can occur as a complication of a pneumococcal pneumonia. So, ladies and gentlemen, please listen up, and then listen up one more time. Empyema. Empyema is a collection of purulent material in the pleural space, and this should be drained by the insertion of a chest tube. Pleurodesis is the injection of a sclerosing or scarring agent into the pleural space, and this may be performed after the empyema has been resolved to prevent reoccurrence. Ladies and gentlemen, please take note. Some other significant complications will include bacteremia, which is bacteria in the bloodstream, atelectasis, a complete or partial collapse of the lung, more typically seen in the postoperative or immobile client, septic shock, and acute respiratory failure with multiple organ failure. So some nursing interventions for pneumonia. We are going to assess and we are going to look at neurological function. So ladies and gentlemen, please listen up, and listen up now. Agitation, restlessness, anxiety, lethargy, and fatigue are the result of decreased tissue perfusion from altered alveolar gas exchange. Ladies and gentlemen, please take note. And then we are going to look at vital signs: tachypnea, tachycardia, decreased oxygen saturation, and then fever. So, ladies and gentlemen, please take note of breath sounds, peripheral pulses, and skin temperature and color. Respiratory secretions, they will be thick, purulent, and or bloody. And then we are going to look at laboratory testing, sputum for microbiology, and the arterial blood gases. And this patient should be on intake and output. So some actions, nursing actions for pneumonia. We are going to look at pulmonary hygiene, the incentive spirometer, coughing and deep breathing, postural drainage, vibration and percussion, and then early mobility. Pulmonary hygiene is done to mobilize respiratory secretions and allow for expectoration. So ladies and gentlemen, please take note right now of patient positioning. 4 infiltrates of only one lung. When turning, please position the client with the good lung down to maximize the ventilation and perfusion of functional alveolar units. So a left lung infiltrate, we are going to position on the right side. Ladies and gentlemen, please take note. We are going to administer humidified oxygen as it is ordered, and we are going to monitor intake and output. We are going to activity group. We are going to approach activities of care with intervals of rest. Fatigue and decreased tissue oxygen delivery will limit activity tolerance. And then we will administer antibiotics as ordered. So, teaching for pneumonia, hand hygiene and respiratory etiquette, encourage adequate rest, take antibiotics as prescribed, stress the importance of finishing all medication even if clients begin to feel better. Please remember that antibiotics can offer a cure for a bacterial infection, and then encourage proper nutrition and fluid intake. Ladies and gentlemen, please take note. Understanding of signs and symptoms indicating worsening respiratory status and how and where to seek medical attention. And encourage at-risk clients to get a pneumonia vaccine every 5 years. Ladies and gentlemen, please take note. And then evaluating care outcomes for pneumonia. How do I know that I've done a good job taking care of this patient? Clients with mild cases of bacterial pneumonia are successfully managed as outpatients on oral antibiotics. Most clients with pneumonia requiring hospitalization will fully recover from their illness and are discharged without complications. So, tuberculosis. Tuberculosis is a significant and potentially life-threatening respiratory infection that is caused by the organism M. tuberculosis, which is an aerobic acid-fast bacillus. The CDC will monitor the prevalence in the United States. It is a persistent problem in the homeless and incarcerated populations. So, the pathophysiology and clinical manifestations of tuberculosis. It is typically transmitted by aerosol droplets that are inhaled from the coughing and sneezing of an infected individual. Droplets are tiny and can remain suspended in the air for several hours. In close contact situations, those with infected sputum are most likely to transmit the infection. Bacilli that invade the mucociliary escalator defense are deposited within the alveoli and are quickly engulfed by the macrophages. Once ingested, there is a slow but continued multiplication of the bacilli. So, TB is classified as latent tuberculosis, primary tuberculosis, primary progressive TB infection, and then drug resistant. So, latent tuberculosis infection. In those individuals with an intact immune system, a granuloma forms and limits further proliferation and spread of the mycobacterium. Necrosis at the center of the granuloma will lead to fibrosis and calcification. A calcified granuloma, evident on the chest x-ray, is a classic sign of TB termed latent tuberculosis infection. These patients have no symptoms, they do not feel ill, and they are not contagious. As long as the immune system remains intact, the bacilli remain in the healed tissue of the granuloma for the individual's lifetime, and this will not progress to a TB infection. The most common factors associated with reactivation are HIV, long-term diabetes, chronic renal disease, long-term steroid administration, sepsis, and malnutrition. So, primary tuberculosis infection. Individuals with a weakened immune response are unable to control the multiplication of mycobacterium. The granuloma formation is initiated but is unable to progress to calcification. This patient is often asymptomatic, and it is confirmed only by positive sputum cultures and a positive skin test. And again, this person is not infectious. Now, ladies and gentlemen, listen up, and then listen up one more time. Systemic TB infection. This is referred to as a primary progressive TB infection. The patient develops a very small percentage, this addresses a very small percentage of individuals who have been exposed to the bacterium. Initial symptoms are relatively nonspecific. My patient is tired, they may have some weight loss, and night sweats. A cough develops eventually and produces a rusty colored or blood streaked sputum. As the disease progresses, dyspnea, orthopnea, and rales will become evident. Ladies and gentlemen, please take note. And then drug-resistant Mycobacterium tuberculosis. This can be monodrug or polydrug resistant. This means that one or more of the first-line medications used for the treatment of TB are not effective. This can be caused by primary or secondary means. Primary resistance is caused by person-to-person transmission of the resistant organism. Secondary resistant TB will develop during treatment and results from an ineffective or incomplete treatment regimen. So, management of tuberculosis. How is it diagnosed? Diagnosis is made by laboratory testing, a skin test, and a chest x-ray. Laboratory testing will consist of a sputum test for culture and then acid-fast staining. The skin test is a positive purified protein derivative, otherwise known as the PPD screen skin test, also called the MAN2 test, the standard method for determining if an individual is infected with the TB-causing organism. So, ladies and gentlemen, listen up, and listen up one more time. Treatment of tuberculosis. Goals of treatment are to cure the client and to minimize transmission to other persons. A basic 4-drug combination is recommended and should continue for 9 to 12 months. Basic treatment is broadly acceptable. Modifications may be necessary in special circumstances, such as pregnancy, drug resistance, and for children. On page 498, there is a safety alert. You will know the safety alert. So, complications of tuberculosis. Extensive respiratory destruction can lead to respiratory failure, bronchopleural fistula formation, and this is an air or a fluid sinus tract that will develop between the bronchus and the pleural space. And then pleural effusions. These are collections of fluid in the pleural space. So extrapulmonary TB can present as meningitis, lymphadenopathy, a bone disease, and liver and kidney failure. So nursing management of tuberculosis, unexplained weight loss, night sweats, fever, and chills are seen as a result of the inflammatory response. That rusty colored sputum will occur as a result of the destruction of lung tissue during this granuloma formation, and then pleuritic chest pain that is a result of the chronic coughing. So, ladies and gentlemen, listen up, and then listen up one more time. Nursing interventions for tuberculosis. We are going to assess. We're going to look at temperature. Fever is a result of the inflammatory process. And then sputum, that blood-tinged or rusty-colored sputum. And then breath sounds. Wheezing from irritated airways will produce bronchospasm, rales, and bronchi from fluid or exudate. And then oxygen saturation. Decreased oxygen saturation will occur with the destruction of lung tissue, lessening surface area for air exchange. So, actions for tuberculosis. Ladies and gentlemen, please take note. Listen up. Isolation. TB is an extremely contagious disease. It will require a negative airflow room. So, stands to reason that no equipment can be brought into this room. So, what is going to happen? What may happen is that your patient is going to have to be transported for testing. So, you will mask the client during transport. And because these droplets are so small, you may want to use some eye protection when you are rendering care. And then humidified oxygen, maintain the integrity of the mucous membranes, and ensure adequate nutrition. Clients may report substantial weight loss during the time prior to diagnosis, and we will administer antibiotics as ordered. Ladies and gentlemen, please listen up, and then listen up right now. Teaching for tuberculosis. We will stress the importance of skin testing for individuals living with the infected person. Ensure that the client and the family understand the importance of completing all medications. Assess the client's support systems and community resources that will ensure successful adherence to the treatment plan after discharge. And then, ladies and gentlemen, please continue to listen up. Evaluating care outcomes for tuberculosis. Successful treatment requires early detection and a comprehensive multidisciplinary structure that addresses the clinical, psychosocial, environmental, and financial issues. So, because of the long treatment period, clients need to be encouraged to follow the prescribed plan of care after they are discharged into the community. Home health will watch and monitor the patient to see every dose of medication is taken. And indicators of resolution are the ability of the client to gain and maintain a stable body weight, improved skin turgor and muscle tone, absence of cough and sputum production, unlabored breathing, and the sensation of fevers and or night sweats. On page 502, ladies and gentlemen, there is a short box referring to transitional care for the patient that has tuberculosis, and you will know that box. Ladies and gentlemen, thank you again for your time and attention. And as always, if you have any questions, comments, concerns, please do not hesitate to reach out.